look forward to hearing from Himanshu, and let's go on to the discussions after that.
Good afternoon, friends. I'm reminded of Richard Bach, who said that there is no such thing as a problem without a gift for us in its hands. We seek problems because we need those gifts. Now, friends, it's a no-brainer right now. I don't need to talk because my previous speaker has spoken everything about me. He hardly needs any justification. He has helped me. Everything he mentioned was to help me in what I'm going to say in the next part coming over. Let's accept it that there is no place for monofocal left in this world, right? Anywhere. Cost is the least of the criteria. Patient want depth of field. Patient want everything. I'm a multifocality guy, but since I'm speaking on extended monofocal, I have to restrict my talk on this. And the answer is enhanced monofocal is the only way out. The pharma, the companies have really not grown up. The optics have not grown up so far. It's like, once upon a time, we had to be paying for the UV blocking and we had to be paying for aspheric. Now, why was it not there? That's because the problem was the industry never helped us. And they always wanted to make money on certain things. So if there is a lens which is available, monofocal will be 100% replaced. Forget the cost. As the whole thing goes on further, will be replaced with the enhanced. And let's accept it. Why do we need it? We need vision at all distances, near, intermediate distance. No question. Everybody wants to see. If they can't see their WhatsApp by evening, you're not a great surgeon. So when you are having that particular, so what we need is that monofocal single point of focus provides good vision at only one distance, requires reading glasses, multifocal, greater spectacle independence, contrast problem, glare problem. So what we need is good vision at all distances, minimal glare and halo, and no loss of contrast. It could be aspheric, diffractive, accommodating, whichever lens that you want to put, you can put that. But that's what the patient wants ultimately, that they don't want loss of contrast and they need vision at all good distances without glare and halo. Well, there comes the answer. What do? Enhanced IOL. Industry may say anything because they want to make money, but let's come to the optics and the importance from the patient's perspective. There's no reason to use a monofocal when you have this lens available. You want to give the depth of field. You want to give them all possible vision. You have a lovely EDOF kind of a multifocal available without any glares and halos around that, no rings. It has multiple defined areas wherein you can see distance, intermediate and near, and both eyes together, you'll be able to see even near. So the extended monofocal would be the way to go around. And that's the most important thing. Well, the design, based on the refractive technology, no rings, has a continuous higher order aspheric, no zones, power increasing from periphery to the center, unique anterior surface, provides good distance vision, provides improved intermediate vision, and gives the patient feeling like that of a monofocal IOL. We have given all these names: monofocal, enhanced, multifocal. What the patient wants is forget any names to be given. They want to see at all distances without glasses given a choice. So the lens that have optic of the IOL has three distinct areas: functional near vision, excellent distant vision, excellent intermediate distance. So positive aspherical aberration, negative spherical, and aspherical monofocal. If you can do that, so that's what you want. Spherical aberration, and the spherical with chromatic aberrations corrected. Provides sharp quality of vision, high contrast images in all light conditions, reduces light scatter. So high quality vision is the way to go about. So if you are going ahead with that, so vision beyond 20/20, enhanced intermediate vision, excellent distance, daytime, nighttime, no difference, no glares and halos. Well, you have the electric typewriter available. Would you do that, or would you be typing on your Word document on your computer? That's no question that whoever till the end was using the electronic typewriter had to die a natural death. It's like a startup. That startup is not going to survive with an electronic typewriter. So also remember, we have, what would you choose? It's a no-brainer. You know how the industry started pushing onto us, that old refrigerator where the cooler was on the upper part, the cooling, the ice was on the upper part. Nonsense. You hardly use it at your high distance. You want food and everything to be there. They just had to change their concept and look at that. And that's what is required in life. So if you have benefits of that, very good intermediate vision, continuous change in the refractive power from the periphery to the centers, no rings and halos, distant vision comparable to aspheric monofocal, spherical aberrations are reduced to minimum, sharp quality of vision, see clearly in low contrast situations, high quality material, no glistening, no light scatter. So intermediate distance activity, driving, including night driving, reading price tags when shopping. Of course, that's very important for housewives. They want to see that. They want to see the rates at which things are going. watching television, subtitles, cooking and eating, playing cards. Oh yeah, I like to see the cards on my neighbor more than my cards, generally speaking, when playing a game of cards. So reading at a computer, tablet, smartphone distance, playing a piano or other instruments, feeling confident while walking. You don't really have to have a great problem with monovision, where you might have problem with depth of field. So
So
what
minute
does it
remaining.
mean? Choose the best. Yes, I'm done.
Good afternoon,
So I
Dr.
just
Amit.
wanted to
How
share
are
with
you
the
doing?
cardiologist whom I operated with the iHands.
Thank you.
We did your cataract surgery with the iHands lens now.
Yes.
And we did distance here. You can almost read the last line both places.
Yeah.
And you did your interventional surgery also. You did your.
Yes.
How are you feeling?
I'm feeling great. I'm coming from the surgery only, and it's fantastic. I mean, the vision is great. I can look at the tissues so well with vivid colors, and minutest breather can immediately pick up, and the surgical time has really gone down. I mean, I think there is a.
I rest my case. I just, for the interest of time, if I say going further ahead, forget the cost, forget anything else. The patient has to be given the best possible thing. The industry will grow to it. If you are using a monofocal by any chance, I'm saying I'm for a multifocal, I'm multifocality. But if you're using a monofocal, there's little choice in my mind but to use what I'm saying, extended enhanced IOL. So the industry says, but that's what the patient needs. Thank you.
Thank you. Thank you very much, Dr. Himanshu and Sartaj. And we shall go on to some few very relevant questions, which I would want to take with the expert panel, and the speakers are welcome to add their inputs. So now, let's look at the questions for monofocal. Like, would Dr. Titial or Dr. Bhasin could answer, would you want to actively think of doing a little micro monovision and targeting a little myopia in the other eye in your monofocal group, or you would straight away give them reading glasses?
I think, monovision, the number of patients requiring or opting for monovision is quite a significant number of people. If you look at large number of practitioners, not like Himanshu, who does mostly a multifocal implantation. We still do a large number of monofocal lenses. What is important is whenever we implant bilaterally, it is the binocular vision, which is the important point for us. That means the stereo acuity of these patients. As soon as we think of a monovision in a monofocal lenses, it has to be minus 1.5 difference in two eyes to have a monovision. The entire stereo acuity goes down to a very basic level. So don't achieve stereo acuity. So monovision in a monofocal lenses is not a concept at all. It is only meant for a multifocal lenses or trifocal, where we can achieve a micro monovision, and that can not reduce the stereo acuity.
Very relevant.
That is one point. Second important point, what both highlighted is monovision. Whatever lenses we opt for a monovision, they should give a distant acuity. At least that should be perfect. And the new lenses which has come up with little bit of enhanced technology for intermediate vision, they also have given us a good distance vision. That's I think advantage we have now. But it's important to see these patients for the next 5-10 years, how people adapt to these lenses in terms of totally taking out the existing monofocal lenses, which Himanshu was talking about.
But in relevance to that, if Dr. Virendra Agarwal or Dr. Purendra Bhasin could answer, would you, if a patient regrets that he did a monofocal in one eye, would you think of putting a piggy bag multifocal in that eye? Or would you even think of doing a multifocal in the second eye for him? Would you all consider that in your practice as a part of your practice? Others also.
Thank you, Dr. Chitra.
2-3 sentence answers, very crisp, so that we have more questions.
I think it all depends on the lifestyle of the patient. This will depend on the lifestyle and use of the. If a housewife is there, then there is no harm in putting multifocal IOL in or trifocal IOL in the other eye if she or he is having a monofocal IOL, and an elderly patient who is not driving. And in such cases, we can do multifocal IOL in the other eye to give them a good quality of life. They can see for distance as well as near.
Have you A piggyback multifocal in the sulcus of these patients who have had a monofocal in that eye?
I will not think of that because unless until there is a residual refractive error present along with the previously operated monofocal IOL, then we can consider of doing a piggyback IOL.
Right. And then any other thoughts are most welcome to add, because I think we should really, there should be a strong.
Chitra, can I say something, Chitra?
Yes, Himanshu.
Himanshu, if it is monofocal, I would definitely go for monovision. No question, as Dr. Tityal was saying. No question about it. And today, as I say, most patients don't necessarily love distance vision, but if they don't see their WhatsApp by evening, they are very unhappy. They want to see near and intermediate as much as possible. If you can't see the ticker while Arnav is chillaving there on CNN headlines, it's fine. But they want majority of their vision to be there without glasses, even if it's a monofocal. And using one eye multifocal, another eye monofocal, not a bad idea. Done it in enough number of people and they are quite happy.
Okay, then going back to the other question of who are the people who would most benefit? Anagha, would you want to take this? Who are the patients who would most benefit from enhanced monofocal? Would it be the myopes or the hyperopes, you think?
Yeah, ma'am, it's always been known that hyperopes usually do well with a multifocal IOL. And in fact, like what sir was saying, one eye multifocal, one eye monofocal, in fact, Eyehance and these ADOPs, which give good intermediate vision, really work very well. Even I've used it in lot number of patients because the chances of glare and halos is much less, plus you're giving them good intermediate vision. But myopes, low myopes, I think we need to be wary of because even otherwise they were seeing well without glasses. So we need to be a little careful about those patients.
Lower myopes are the biggest cribbers because they are used to reading without glasses.
Exactly.
If you give them distance here, they are.
Dr. Ramamurthy, I wanted to ask you, if you're looking at Eyehance and the patient has astigmatism, would you, if it's a small amount, would you believe that you want to give him Eyehance, but you would do a little arcuate keratotomy and get done with it? What would you say?
Obviously, I would like to deal with the astigmatism if it is pre-existent, but I think if it's significant, I would rather go for a toric monofocal or a toric multifocal. Unfortunately, as was mentioned in Eyehance, the toric variety is not available. I think Shartaj did the right thing by not quoting papers or anecdotal experiences, but the DFU or the directions for use from the company itself. Let us understand that the DFU for the Eyehance is, it gives you a 0.5 diopters of enhanced vision for intermediate vision. It does nothing to near vision. The best thing the company did is gave us little and priced it little also. Obviously, if it is priced at 25,000, none of us would be using it. I believe Eyehance is a good lens, a great lens. I think you pay peanuts for it and you get peanuts from it.
Okay.
Minivel is one lens.
One very last question I'm going to take.
Time's up.
Yeah, dissatisfaction after enhanced multifocal. So whom would you not prefer to implant? A final take-home message anyone could answer. Which patient you would not suggest an enhanced multifocal at all?
If the patient has expectations of multifocality, just because they're paying a little more, that's all. Otherwise,
right. Absolutely.
Right.
It's like a monofocal lens.
Okay. We shall, that was nice. I'm sure there would be many more questions which we can always take on later. And you can even make note of it. We could take these